Cognitive behaviorist therapy practice of the last couple of years has been quite interesting, and talking about it is much easier than practicing it. Metacognitive therapy might sound quite complicated for those of you who are getting acquainted with it for the first time, but it actually is a relatively easier therapy. Metacognition is a term which is stemming up from developmental psychology. The term comes from developmental psychology. I have Turkish slides as well. Could you please put those on the screen, please?
Şimdi ikisi de Türkçe oldu.
Now they're both Turkish.
Yabancı dinleyicilerimiz de olduğu için bekliyorum biraz.
I'm waiting for the English version as well.
Biraz devam edelim. Metakognisyon.
But anyway, metacognition can be translated into Turkish as supreme cognition. The upper cognition, the child learns something but doesn't know that he or she is learning, knows something but doesn't know that he or she is knowing something, and as the person grows up, starts having a metacognitive capacity. And the meaning in metacognitive capacity is cognition about the cognition, cognition of cognition, which is ideas about the ideas. This is what makes metacognitive beliefs. And metacognitions tell us gives the shape of the content of the ideas, and they have an effect on the strategies. Metacognitive therapy's founder is Adrian Wells, and Adrian Wells says that it is a cognition which controls the behavior and idea that emerges in response to a certain act. The English slides are going to be ready in 1 minute. The metacognitive theory has certain meta features. When we say meta, we actually talk about something beyond something beyond cognition. So metacognitive therapy is beyond cognition. This is what we can accept. One of the most important characteristics here is that the negative ideas are universal. The only way that makes this understanding is different is that everything can have a negative component. You might have an external event, you believe something about that event, and you develop an emotional reaction against that event. So metacognitive therapy's approach is not like that. Metacognitive therapy does not look into the cognitions depending on external events.
Okay. Tamam. Bir başka bakış.
Another perspective is that the negative thoughts are universal while psychological disorders are not. I mean, having negative ideas do not lead into psychological disorders, because everybody has negative ideas, but not everybody develops depression or anxiety disorder. So what controls the thoughts, what decides who can avoid those, but what decides who is going to have long-term complications is actually metacognitions. So metacognitive therapy does not deal with what the person thinks, but how the person thinks. So this decides whether there will be a control over the ideas, whether a pathology will be developed or not. And there is a syndrome. What causes psychological disorders are metacognitions, which present a response style to inner experiences in a way that prolongs negative feelings and strengthens negative beliefs. This response style is determined by cognitive attention syndrome. It has three components. One of them is perseverative thinking style. It is in the form of worry or rumination. When we say how the person thinks is important, we actually mean to say that the person is overthinking, is too anxious, or as it is the case in depression patients, too much time is allocated to rumination. Threat monitoring is also important. Those threats might be external or internal. People may have their own triggering thoughts or ideas, and people might focus on those only. And the third component is an unhelpful self-regulating strategy or coping behavior like thought suppression, avoidance, substance abuse. So the key principle in metacognitive therapy is that mental disorders are related to the activation of a toxic cognitive style, namely CAS. Activation of this prolongs negative beliefs and feelings and makes them repetitive. And we talk about metacognitive beliefs. We're grouping them as positive and negative. What we call positive metacognitive belief is having beliefs about the advantages of using those. I mean, if I always focus my attention on things I'm scared of, then I will be safe. Or worrying about the future keeps me away from the danger. So anxiety, rumination continues, and these are being picked as a strategy choice. So I'm talking about the positive ideas which leads to those. On the other hand, negative metacognitive behaviors are also seen in people. That means dangerous thoughts or inappropriate meanings and importances attributed to those thoughts. People thinking that they have no control over thoughts and thinking that what they're thinking about is actually dangerous. People thinking that anxiety will give harm to their bodies, etc. Two mental modes are there in metacognitive therapy. One of them is the object mode. Fatih Bey a few minutes ago talked about mental fusion. This is the same thing with mental fusion. We are all prone to be involved in a default processing mode, and the object mode is this default processing mode. And we're not seeing things as an inner event, but integrating a thought with the reality. We think that what arises in our minds is actually the reality. In metacognitive therapy, this is the mode that we're trying to induce in the patient. This mode we call metacognitive mode. Means that the thoughts are separate from people's existence. And it depends on the inner experiences. It is shaped by the inner experiences of people, and it brings us the ability to connect ourselves with this. Detached mindfulness is a very good summary of this. The metacognitive mode is being induced for this, is being used to induce this, for example. What is this mindfulness? Metacognitive. Well, this mindfulness is different from the other ones. One thought or an image or a feeling has a certain objective awareness. There is a triggering idea, whether it's being OCP or PTSS, it doesn't matter. One should understand that it is just a thought, and one should understand that it is only something in your mind. This setting a distance means not being involved in an activity and being able to differentiate you and your thoughts from one another. You are not your thoughts. Your thought is not you. So this is a mindfulness which includes a certain distance. Of course, it represents an alternative way of processing as a contrary hypothesis of the philosophy we're talking about here. Psychological disorders are related to the loss of attention and flexibility. Also, threat monitoring prevents the individual's access to information that might change his or her false beliefs. A metacognitive therapy has a self-regulating executive function model. This model includes 4 important concepts. It is not that complicated. What I've discussed until here make up those 4 components of those: cognitive attention syndrome, metacognitive beliefs, attention control, and mental modes. This is a therapy which is called for depression and anxiety disorders mainly. Extensive generalized anxiety disorder is where this is being used most of the time. There is a triggering effect here, and that triggering effect is not something external. It is an inner event. It may have an external resource that reminds you of that, but when you call a trigger, we actually think about an intrusive idea. And at the back of someone's mind, if there is a positive thought about getting anxious or anxiety, those positive beliefs get activated and type 1 worry is observed. For example, it might be a triggering idea of your daughter having a car accident, etc. So if you have positive mental beliefs activated, then you're going to have a type 1 worry, and it's going to be a chain of anxieties. But when the negative meta beliefs are not activated and stayed here, there wouldn't be any problem. There wouldn't be any problems. But in a generalized anxiety disorder patients, the other types of worries are also triggered. So when that happens, they start worrying about their worry. And as people become more anxious, both types of worries increase in amount. And against type 2 worries, thought control strategies are used. As Fatih Bey mentioned, they try to suppress their thoughts. When they cannot do this, they worry more about the worry, and they think more and try to get rid of this situation, and they cannot do it and get worried again. They try to cope up with some behavioral strategies. They look for certain guarantees, and as they cannot succeed in that, they are left within that vicious cycle. So when we say type 1 anxiety, we actually talk about ordinary cognition. Worry is chosen as a coping strategy in relation to beliefs that many people have to some extent. I mean, it's the negative interpretation of the thought itself, and the generalized anxiety disorder develops when the negative beliefs are triggered. This is an example. When an intrusive idea comes, the positive ideas can be triggered, and as a result of this, worrying is harmful and uncontrollable. If this is what they think, they start saying, I can cope, I'm going crazy, etc. This is how the cycle goes on. This is a formulation based on the shape I've just shown you, and there's a rationale that is set forth. The induction of the metacognitive form, and then negative and then positive metacognitive beliefs being tested. But type 1 worries content is never talked about here because they are already not metacognitions. In terms of being evidence-based, this is going a little bit from behind when compared to the other therapies we've discussed today, but the opening speech of the distinguished chairperson has given me a little comfort because it started with an open trial. Significant improvement was reported in all participants with large effect sizes. Comparative studies were done in 2010 for the first time. A large-scale study demonstrated superior efficacy for both cognitive behavioral therapy and metacognitive therapy over a waiting list control condition, but with its improvement rate of 72%. In 2012, there was a study compared to BDT. Metacognitive therapy was found to be stronger than BDT. This is applied relaxation study by Wells and his friends. Here you have almost 80% recovery rates, but in applied relaxation, instead of 30 to 40%, you have something low as 10%. This is a study from Holland. Again, this is intolerance of uncertainty therapy for generalized anxiety disorder, and it is proven to be quite efficacious, so it is actually appropriate for a proper comparison. The number of patients is also high, 126 patients, and against the BDT form, metacognitive therapy seems to be doing much better. And when you look with the other studies, you see that the effect sizes for metacognitive therapy are quite promising. And when you compare it with intolerance to uncertainty therapy, you can see that the results are much better. A case series in OCD, metacognitive therapy and fluvoxamine were compared in this small-scale study. In PTSS, a series was formed in 2004 for the first time, and in 11 out of 12 patients, significant improvement was observed. Last year, a randomized controlled trial was conducted, and it is found to be more advantageous than PTSS, and it was compared with the exposure therapy, that is the golden standard, but the results are positive again, and it is even much better than exposure theory in one of those trials. In depression, in resistant depression cases, we have very small-scale data. Resistant depression or anxiety disorder group might benefit a lot from this therapy, according to the evidence. This is another study by Wells on treated patients. The number of cases is really low. Significant improvement is seen only in 8 out of 10 of those patients. Cognitive behavior therapy started with Beck's depression therapy. Generalized anxiety disorder was the starting point. Then everything got widespread. It could have been faster, but the attention deficit method being used in psychology and then we see that the method develops within time. For more information, you can resort to metacognitive therapy for anxiety and depression and the website. These are 2 very important resources for metacognitive therapy, and these are basic information. This is CBT distinctive series feature. It's about all approaches in CBT. These are separate drugs. All subtitles of CBT can be found here with their differences from other therapies, and this is important in terms of understanding metacognitive therapy. Thank you very much for your attention.